Now let's continue our discussion of OELs a little bit more. OELs are typically very complex. There are a variety of OELs depending on the characteristic of workplace and work practices and the needs that are to be addressed with the exposure assessment. And a particular OEL has a variety of components that must be understood, as we discussed a little bit earlier. This understanding is important so that we can apply the limit appropriately. And in the next few slides, we'll talk about a few definitions that provide us insights into how an OEL should be applied. So what are the different types of OELs? The first kind of an OEL is a time-weighted average OEL, usually associated with an 8-hour workday, 40-hour work week. And such OELs are for protecting workers from chronic health effects, meaning if a worker were exposed to this particular agent for weeks on end for an entire career for many years, then the average exposure that the worker is facing should be less than this particular number, the TWA OEL. And this particular OEL can be also adjusted a little bit to allow for other work shift configurations. For example, you can adjust it to account for a 10-hour workday or even a 12-hour workday, or is it a day shift or night shift? So those kinds of adjustments can be made to the time-weighted average OEL, and it is specific to managing chronic exposures. The second kind is called a short-term exposure limit, or a STEL, and it is usually averaged over 15 minutes. And as you can possibly guess, this is for protecting workers from agents that might cause an immediate effect or an effect after just a matter of a few minutes. So these are not for chronic effects, but acute health effects. There is a third kind called a ceiling OEL, and sometimes referred to as a peak. And these are limits that should never be exceeded, even for a minute or even a second. So these are called ceiling exposure limits. So what are the components of an OEL? First of all, we need a concentration in units of parts per million or milligrams per cubic meter for an airborne contaminant. This is related to the chemical's potency to cause harm. And so note that a high potency means that a health effect occurs at a very low exposure, but the potency does not necessarily imply the seriousness of the effect. So you could have a chemical that causes an effect at a very low level and acts as a central nervous system depressant, and you could have another one that at a very low level acts as an irreversible neurotoxin. So clearly the second one is more serious, but the OEL does not really differentiate between them. It just gives you a number that is low, and it says if you exceed this, there is a likelihood that the worker would suffer central nervous system depression or irreversible neurotoxicity. The second component of an OEL is an averaging time. So as we saw in the previous slide, we need to manage both chronic health effects as well as acute health effects. And so what is the averaging time over which the measurement is being made? So that is the averaging time of the OEL to which the exposure needs to be compared. So is it an 8-hour work shift average, or is it a 15-minute short-term average? The third component of an OEL is the adverse impact at the concentration level. And a given chemical can cause more than one adverse effect. And it could act as an irritant in the short term, and it could cause lung damage over the long term, or it could act as a carcinogen over the long term. And so that needs to be understood. And then finally, what is the target population? Is it general workers, or is it a particular subgroup that is susceptible? We'll talk about one of the most common and most influential exposure limits out there, and these are the ACGIH TLVs. So ACGIH is the American Conference of Governmental Industrial Hygienists, and the TLV stands for Threshold Limit Value. I'm just going to read the definition of the TLV that the ACGIH itself has provided. Threshold limit values, or TLVs, refer to airborne concentrations of substances and represent conditions under which it is believed that nearly all workers may be repeatedly exposed day after day without adverse effects. And it accounts for a wide variation in individual susceptibility that arise due to genetic factors, age, personal habits, medication, or previous exposures. Such workers may not be adequately protected from adverse health effects from certain chemicals at concentrations at or below the threshold limits. So let's sort of go back and look at each one of these bullets. First of all, it's saying that it is not going to be protective of all the workers, but nearly all the workers. And how do we operationalize it? What does nearly all mean? For a wide range of chemicals, the nearly all refers to 95% of the workers. That is the operational definition that people have adopted for most chemicals in the chemical manufacturing industry. In the pharmaceutical industry, nearly all refers to 99% of the workers. So that's what nearly all has been taken to mean by different industries. But the ACGIH itself has not provided this definition. They just want to be clear that it's not going to protect 100% of the workers, but most of the workers. The second caveat to this definition is that the ACGIH recognizes that human beings are different due to a variety of factors, and so some workers would not be protected because of these factors that are listed. There are genetic factors, age and habits and medication and so on. And so such workers would most likely not be protected. So the idea is that the TLVs would protect the vast majority of workers who don't have these susceptibilities that have been listed. So the TLVs and other OELs assume that for every substance, there exists a concentration below which no adverse health effects occur, no matter how frequent the exposure. Again, you should keep in mind that this is not referring to the susceptible subgroups. So if we now just look at the 95% of the workers that are going to be protected, it's basically saying that below a certain concentration, there will be no adverse health effects, and that is the threshold. But for carcinogens, there will not be a threshold, because for chemicals that act as carcinogens, even one molecule is sufficient to trigger the chain of events that could cause cancer eventually. So there is no threshold or a dose at which there is zero risk, but people have adopted a risk threshold, such as 1 in 1,000 or 1 in 10,000 for setting the exposure limit. For example, in the early 1980s, the background workplace mortality risk was estimated to be around 1 in 1,000. And what it means is if you have an exposure to a chemical carcinogen, then the acceptable risk threshold is 1 in 1,000, meaning we can, as a society, tolerate 1 in 1,000 workers to suffer the health consequence, in this case, some kind of cancer. And so that is the threshold at which we set the TLV. For non-working populations, ordinary citizens who are not in a particular industry, the threshold is much lower. So it could be 1 in 100,000 or 1 in a million. So as a citizen, you and I can expect to be exposed to chemicals in the outside environment because as a society, we have decided that we can have exposures to chemicals in the outside air where it's okay if 1 out of 1,000,000 citizens gets cancer because of that level of carcinogen in the ambient air. In the workplace, though, the mortality risk that we can tolerate is 1 in 1,000, and that is the basis on which the TLVs have been set. Currently, the ACGIH TLVs are set on the basis of available occupational epidemiologic studies and animal toxicology tests. There have been conflicting interpretations of the exposure limits for chronic diseases. Steve Rappaport in 1991 interpreted OELs to represent long-term limits of time-weighted averages. The basis for this was the phrasing of both the ACGIH TLVs as well as the OSHA permissible exposure limits that say that these limits are time-weighted average concentrations for a normal 8-hour workday and 40-hour work week. Since it's sort of indicating a long-term career of being exposed to this particular chemical agent, Rappaport and others interpreted the OELs as long-term limits. And OSHA equates risk with cumulative exposure, and since the mean exposure is the best predictor for individual risk, the OSHA PEL should also be interpreted as the average exposure received by a worker or an SEG of workers over a 45-year hypothetical career or time period of exposure. In other words, the conventional time-weighted average OEL should be interpreted as the upper limit to the long-term average exposure experienced by each worker. And so in such a case, a sampling strategy would focus on determining the probability that any worker in an SEG experiences a long-term average that is greater than the OEL. So this is all one interpretation of what an OEL means. The alternative interpretation, and this is the more common interpretation, is in fact by OSHA itself. OSHA has not accepted the Rappaport interpretation. In fact, they state that PELs are levels that should never be exceeded for any shift-long measurement. So even one 8-hour average measurement should not exceed the OEL. And so they're not talking about a 45-year time period. They're talking about one shift. And so OSHA defines a workplace to be in compliance only if all the measured exposures are less than the permissible exposure limit and not just the average. So even if a single measurement exceeds the PEL, the workplace is declared to be out of compliance. However, as we can guess from our discussion of exposure distributions, this is really an impossible requirement, since workers' exposures form a distribution in which the PEL is but 1 point. And based on the estimates of the parameters of an exposure distribution, we can easily calculate the frequency with which the PEL is exceeded in a given workplace. And we have, in fact, done these calculations using the IHStat spreadsheet from the previous lecture, where you could calculate the exceedance fraction. A third interpretation is that TWA OELs that have been issued by ACGIH, OSHA, and NIOSH are concentrations averaged across each shift that should not be exceeded. But here, the sampling strategy focuses on determining the probability that an arbitrary worker in an SEG experiences a shift-long exposure, and we use a statistic such as the 95th percentile of the exposure distribution is compared with the OEL. So if the exceedance fraction is less than 5%, then we say that the worker's exposure is controlled. So here, we are not looking at the long-term average, and we are not looking at each single shift measurement and comparing it to the OEL. We are instead taking several measurements, and we are then estimating the 95th percentile of the exposure distribution and then comparing that percentile to the OEL. So this is the third interpretation of the OEL. And in fact, it makes the most sense because we really want to protect most of the workers all the time. So by saying that we'll be using the 95th percentile, we are essentially saying we want to protect 95% of the workers all the time.